Welcome back to Therapeutics. In this block, we're going to quickly review pharmacotherapy for infertility. We'll talk about male sexual dysfunction and also the use of androgens. The other thing we'll talk about in this block are drugs used in pregnancy, labor, and even a bit about drug use and lactation. We'll look at androgens and sometimes in combination with some of the other products in infertility. I will tell you that in practice I have very little experience here. So I would defer you to the experts here in managing infertility. But typically the situation for patients or couples who come to you with infertility, usually you'd expect that if a woman is not using birth control or a couple is not using birth control methods, there's about an 85% chance that there will be pregnancy over a year. And most women have their babies younger, but keep in mind that there's a fair number of women now who have their first baby at the age of 35 or after. But once we get over the age of 30, the likelihood of having getting pregnant it diminishes with each month. The things that can enhance fertility, looking at diets that are appropriate proteins, fruits and vegetables. For men, making sure they have enough zinc in their diet, exercise. Although not too much exercise, you'll hear often that women who have very excessive exercise, runners, for example, who lose a lot of body fat, actually won't ovulate. So you want to make sure that it's moderate exercise, not overly excessive exercise. And then maintaining a BMI that is sort of appropriate as associate or a goal between 25 and 30 is associated with the improved fertility. So we're typically would define infertility as a couple who has tried to conceive over a year and has not been successful. And then the causes for men could be endocrine or anatomical or could be even sexual dysfunction. For women, it could be ovulatory, cervical, or pelvic. And then for women, particularly if they've had polycystic ovarian syndrome or endometriosis, pelvic inflammatory disease, either uterine fibroids or some other etiology is often what contributes often to female infertility. So getting those issues to the extent addressed appropriately by a gynecologist can be helpful in addressing fertility before you start to go to some of the other therapies that might be considered. Fertility agents used, the drug therapy that's considered, among other things, historically has been clomiphene. Clomiphene is used to induce or stimulate ovulation. The issue with clomiphene is that while it's considered a first-line agent, it will work to affect estrogen levels in such a way that you could have excessive ovulation. So sometimes when we give the therapies for infertility, you'll find that these modalities actually increase ovum production, and what you'll end up with is a higher potential for multiple birth pregnancy. Another issue you'll think of in managing infertility is human menopausal gonadotropin. There are a couple of different products here. They're derived typically from urine in postmenopausal women, and they're given at certain points of the cycle, usually pretty well tolerated, at least when I talk to colleagues briefly about this, but is a part of a larger set of therapies that are timed appropriately at different times of the cycle. We also could look at follicle-stimulating hormone being used or luteinizing hormone being used as recombinant formulations, and these would be done really under the guidance of a specialty infertility clinic. These aren't really done as part of primary care, but are done in specific clinics. One of the other issues that think about with all of these therapies for fertility is that at least over the last decade, there's been a lot of variation in what gets covered by insurance and what doesn't. And so with the marketplace having changed over the years, you just want to make sure that because these therapies can be thousands to tens of thousands of dollars by the time they're through with all of these modalities, you just want to make sure that the patient sort of goes in, or the couple goes in, with the understanding of what the expectations are for financial costs and what gets covered by their insurance plan. There's also human chorionic gonadotropin, and there are analogs as well that are used, and these are all pretty much sequenced. I'm not going to go into depth of these. As well as agonists and antagonists that could be cycled at different points to optimize ovulation. So it's all, many of these agents are very specific about the timing of when they're administered to have certain effects on feedback loops or stimulate ovulation. There's a couple other agents as well, not really commonly used, but have a role. One is metformin, and metformin itself is sometimes helpful in ovulation if a woman has polycystic ovarian syndrome. It also will affect insulin secretion. It may be also associated in these subset of women with some degree of weight loss, which also improves to some degree ovulation. The aromatase inhibitors typically are not used for infertility. We'll see those used more often in certain types of breast cancer, but they may actually look at inducing ovulation with less risk of multiple egg formulation, multiple births. A couple other agents that are sometimes added to the mix, and again, this is under the guise of a fertility clinic. Sometimes progesterone is added to maintain the uterine lining support. Rarely, occasionally, you'll see bromocriptine or even sildenafil to affect uterine lining as well as a vasodilator. Let's now look at a few other things. We have ovarian hyperstimulation syndrome. This is a life-threatening complication which could be associated with some of these modalities. It's rare to see it, but it does happen. And typically what you'll see is enlargement of the ovary, and as such, these therapies can sort of pose some risk associated with them. So in your practice, particularly if you're going to be in primary care, this is really something that's going to be dealt with by the gynecologist or the family fertility specialty clinic, really not likely yours, but you need to be aware of this if you see a patient who's undergoing this therapy, to keep in mind that ovarian hyperstimulation syndrome could be present in a patient who's undergoing these modalities. The presentation typically will be a rapid weight gain, often with ascites, sometimes pericardial effusions. You could see hemoconcentration or leukocytosis. You could even see it progress all the way up to adult respiratory distress syndrome with hypercoagulability and organ failure. So it's rare to see it present that dramatically, but it could happen. And so you would want to just think that when you're really moving around with affecting infertility modalities, they have certain high risks and a low percentage of patients, and you need to keep that in mind. If we think of the standard type of role that the pituitary has as it relates to male and female hormone function, we think of the pituitary secreting follicle-stimulating hormone and luteinizing hormone. Follicle-stimulating hormone and luteinizing hormone both stimulate the ovaries to produce estrogens and progestins. And in men, luteinizing hormone also stimulates the production, ultimately, of testosterone. If we think about the chemical structures, and I'm not going to sort of bore you with the chemical structures, but the chemical structure of cholesterol is similar to estrogens, and it's similar to progestins, and it's similar to testosterone. And so particularly as we look at estrogens or progesterones or testosterone, the specific type of estrogen, or more importantly probably, the particular type of progestin might be associated with a little bit more chemical structure similar to testosterone or the androgens. And so we'll find that the specific molecules that are used as estrogen or as progestins or as androgens, for that matter, vary in their sort of ability to have more estrogenic, more progestin, or more androgenic properties associated with them. This review of drugs in pregnancy mimics most of the content we talked about earlier in the year. So we'll try to go through this a little bit more quickly, but as a reminder. So as if you remember, we spoke about pregnancy risks with drugs or chemicals, and we considered teratogen any substance that has the potential to cause abnormal fetal growth or development, and the capacity or capability of that substance to do so is considered its teratogenicity. Keep in mind that most of the time we can't really pinpoint a drug or a chemical as the cause for the teratogenic effect, and typically it's a combination of probably environment and in many cases genetic predisposition as well. If you recall, we discussed a bit earlier in the year about thalidomide and the agent that is associated with major malformations used in particularly the United Kingdom and the United States. So we consider teratogenic effects having a variable effects on a fetus from minor functional changes or anatomical changes to more major ones, all the way up to full pregnancy loss or miscarriage. So the type of etiology of that, the mechanisms involve direct toxicities on embryonic cells or maybe affecting nutritional elements, particularly we think, for example, of folic acid and its effect on spinal cord development, for example. And sometimes we see changes in the placenta or the effect on maternal tissues that indirectly affects the fetus. We also have situations where sometimes we don't see for even decades later what risks are, like the cancer risks associated with diethylstilbestrol use, many even years to decades later. So fetal malformations, they happen at a fairly high rate, depending on the patient and the population studied, up to 3 to 6% of pregnancies. And the etiologies can be lots of things. One of the major ones we worry about is viral exposures, particularly we think of German measles or rubella as a risk in the risk for fetal malformations as well. We also think about the point of development of the fetus, at which point, at which age the fetus is developing which organs or systems, and if the vulnerability of that chemical causes a vulnerability in that organ development, is that window of time of development. For example, cardiac valve changes with drugs would be seen at weeks 3 to 6, limbs 4 to 7, soft palate 6 to 8. And so if the drug's associated with that type of malformation or risk, that's the window of time that's probably the highest. And while risk of many of these agents can be throughout pregnancy, there is often for some drugs a riskier period of time for drug exposure. And for the more significant functional changes or anatomical changes, those are often in the first trimester of pregnancy when a woman may not even know they're pregnant. So we talked about multiple factors that affect teratogenicity, including genetic predisposition, the nature of exposure, the timing of exposure, the nutritional status of the mother. All of these are variable factors that can affect the risk of a particular agent inducing a teratogenic effect. We also worry about what crosses placentas, and so typically a drug that is a very high molecular weight or a drug that is not very likely to cross membranes well might be a safer alternative in a woman who is pregnant or of childbearing age. We also remember we talked about the risk categories. In 1979, the FDA had used a category A, B, C, D, or X. And while those are officially no longer used, unofficially many clinicians still use that terminology because it's a way to somewhat quantify a risk of a different agent when you're comparing agents of which are riskier or not. But that nomenclature was pretty much abandoned. It started to be abandoned about 2008, but really not until 2014 or so. What we know about drug risks is surprisingly little because we don't have great studies for that. Most of it is case reports. or animal testing models that don't always predict exactly what's going on. We talked about that earlier in the year. We also think about what's going to cross a membrane, so large molecular weight substances are more likely not to cross. So given the choice between, for example, warfarin or a heparin product for a woman with a deep vein thrombosis during pregnancy, we're more likely to pick the heparin-related product in general than we are to something that's going to cross the membrane and pose a risk to the newborn. We also talked about drug distribution to the fetus, what is going to cross that placenta to the fetus. But if we can maintain levels that don't drive drugs across the placenta, that's sometimes something we'd consider doing. There are a number of theoretical considerations when we think about the placental barrier to drug therapy. But the big things to think about are, in general, larger molecular weight substances won't cross the placenta as easily. And you really need to look on a drug-by-drug basis to determine which agents are riskier or less risky during pregnancy. The data that has been done is basically mostly limited to case reports, and because it's unethical to really do many other kind of studies, as we talked about earlier in pharmacology. So drug use in pregnancy, we definitely see it. Mostly what we see during pregnancy are vitamins, iron therapy that are ordered, analgesics. Usually we're talking about acetaminophen, and antibiotics or antimicrobials, hopefully using, for example, beta-lactams are generally safer choices. Sometimes azithromycin a safer choice. Would avoid fluoroquinolones, would avoid tetracyclines in pregnancy if we can. The older classifications pre-2014-15 were the A, B, C, D, X categories that still in clinical practice many clinicians still use because it's a way to, in a sense, compare 2 or 3 or 4 choices in a quantitative kind of way. But because this data was originally a bit flawed in how it was developed, the FDA has leaned away from using these categories anymore. So these phases have been largely phased out, and the labeling has changed by the FDA over the last 2 or 3 years. So really the specific label changes that have happened in 2014, 15, and 16 were to look at category labeling for pregnancy, issues for issues with lactation, and then a new category for the potential for male and female reproductive potential that the drug may have, what impact it may have on that. But gone are the quantified A, B, C, D, X categories per se. That happened in late 2014, but it had been coming a long time. You can look at the FDA website for more information on this. So there are certainly, beyond drugs, other known teratogens. We consider certainly alcohol a teratogen. The androgens are, we consider the ACE inhibitors and the ARBs agents to avoid the anticonvulsants. The chemotherapy is opioids are, so we generally try to avoid opioids, heavy metals, and a lot of chemotherapy. Lithium also considered a known teratogen. If we have to use a drug in pregnancy, we usually try to limit it. What we find to be safer choices are, for antibiotics, the beta-lactams, acetaminophen probably safe, and a few other choices. A couple of antihistamines are considered safer. And then the bottom table here are drugs that have been used in pregnancy when on a case-by-case basis, but you'll see drugs listed here that most clinicians would try to avoid if we could do that at all. And so don't take anything on the second lower section of the list, like benzodiazepines, for example, as really safe in pregnancy. They're really not. They're just maybe a consideration based on the risk and the benefit. And the types of adverse effects that you can see with teratogenic effects with drugs can be wide-ranging. They can be future cancers for that child as they get older. It could lead to fetal death. It could lead to hematologic problems. Low birth weight is a very common outcome, but there are others listed here as well. When we think about drug use in lactation, we really try to do everything we can to have mothers really breastfeed. That's better for the newborn, for the infant, and so we really try to do that. There are a couple of considerations that are made. Most of these are theoretical. So, for example, we look at physical and chemical factors that are associated with whether a drug will become trapped in breast milk or not, and the clinical considerations of what's the risk for that newborn or that infant or child being exposed to that drug via breast milk. So for the most part, drugs will cross into breast milk if they're fairly fat-soluble and fairly small in molecular weight. The other issue we spoke of earlier in pharmacology is this concept of ion trapping. So because breast milk, in a sense, has a different pH than blood, what you'll end up with is that weak bases will be trapped in breast milk because breast milk is a little more acidic. And so it will pick up the weak bases, will pick up an additional hydrogen ion, become electrically charged, and then won't be able to get out of breast milk. So for weak bases, there are a fair number of drugs that are, for example, some of the H2 blockers are, which we use, ranitidine, cimetidine, which you don't use much anymore, famotidine, will have higher amounts in breast milk. The issue, though, is even though they have higher levels in breast milk, exposure of those drugs to newborns is really not probably a clinically important issue. We also have protein binding in the blood, which will decrease the amount of drug that will enter into breast milk. So we see that the transfer of drugs into breast milk are a function of whether they cross membranes, what are the concentrations and different compartments in the body, and how do they transfer in and out. There are things to think about that clinicians will think about in general principles. I won't get too hung up on these. But we think about, is it a risk to the infant? Do we know what the experience is of an infant getting some exposure to that drug? So, for example, we don't have a woman who is taking an opioid breastfeed. And the reason is that opioids, being weak bases, will be trapped in breast milk. And there will actually be a fair amount of exposure of the opioid to that infant. And there's a concern that the infant will become habituated to the opioid and then go through opioid withdrawal when the mother stops taking the opioid or at the end of breastfeeding. So that's a real issue we try to avoid. But we think about what the age of the infant is, what the drug and duration is, the amount of breast milk that's consumed, what the experiences of that drug is with infants and the like. And there are ways we can minimize that. The biggest issue is if it's possible to hold off on using that drug while the mother's breastfeeding, that's an issue. But that may or may not be practical to do. What most clinicians will do is they'll probably speak with the lactation expert. In hospital settings that have a obstetric service, they virtually always have someone on staff all the time who is an expert in lactation, and this is an issue that gets brought up to the OB staff pretty frequently. So the ways we can minimize it might be, do we look at avoiding that drug while the mother is breastfeeding, pick different drugs that may be less of an issue. There are drugs that also will increase or decrease milk supply. We don't use drugs to increase or decrease milk supply per se, but you may find that it's an issue that does affect the amount of breast milk that a woman is producing. That's a consideration if that's an outcome that is noticed while the woman's taking one of these meds. There are drugs that are considered relatively safe to use in lactation. Caffeine in moderation is, insulin is safe, ibuprofen, acetaminophen is, the beta-lactam antibiotics and the macrolides are probably safe. But then there are a number of drugs that these should really be clear in your mind that are avoided in women who are breastfeeding. Any drug of abuse, opioids, amphetamines, benzodiazepines, cancer, chemotherapy drugs, nicotine patches are and any of the opioids are. There are also a number of things to think about in pregnancy that are complications that are noted for patients in pregnancy. And these are some of the ones that are listed here: morning sickness, heartburn, constipation, hemorrhoids. We'll go through some of these common situations that are associated with pregnancy and some of the simple things that we can do to manage these conditions during pregnancy. For morning sickness, the issue really is often limited to the first trimester. And many women who go through pregnancy experience this in one way or another. Usually it's seen earlier in the day and usually becomes more tolerable for most women. And the simple thing is for women to find what works for them. Sometimes eating just saltine crackers, keeping something in the stomach. Ginger ale or ginger is considered relatively safe to use in pregnancy, and that's a consideration that a lot of women find helpful, as well as eating smaller meals and not too much liquid early in the day. For symptomatic treatment, there are a number of agents that are used and are listed here. Some of the agents that have been more widely used over the years are listed at the top. Those are former category A or B drugs. And usually choosing one of the A or B category drugs is usually what's done for symptomatic treatment. For heartburn in pregnancy, which is more likely to happen in the latter half of pregnancy, and this has to do with pressure on the diaphragm mostly, we see smaller, more frequent meals are helpful, avoiding food and meals 2 or 3 hours before bedtime, which is more problematic when a woman will lay down, elevating the head of the bed, as we'll talk about as a management for gastroesophageal reflux. Antacids generally are okay to use. Sucralfate's okay, and or maybe a histamine 2 blocker, but those are second-line agents after trying antacids or sucralfate. In constipation, usually what we recommend first off are increasing fiber and increasing fluid intake as that's tolerated, and increasing moderate exercise. And then bulk laxatives are really our first choice, maybe using surfactants like Docusate, but we want to avoid mineral oil, and we want to avoid a lot of more stimulant laxatives when we can get by with particularly bulk high fiber and bulk laxatives like really psyllium or Metamucil. Hemorrhoids also pretty common in pregnancy, and what we'll see here is often using a stool softener like Docusate or a higher fiber diet, maybe with a sitz bath, and using topical anesthetics, maybe a topical corticosteroid as well. Headaches in pregnancy often related to estrogen fluctuation. Treatments usually are rest, ice packs, acetaminophen, really avoiding aspirin, avoiding nonsteroidals, avoiding the triptans, and avoiding opioids. So really you try to avoid all of those things. It really limits you to acetaminophen and rest and ice packs. You always have to think about coagulation disorders in pregnancy when there's a history of a deep vein thrombosis, or there is one actually happening, or a PE, or a woman who might have a prosthetic heart valve or have another reason why they are at risk for a clot. We avoid warfarin. Most clinicians use low molecular weight heparin, Lovenox or enoxaparin for the most part. We do see there is some evolving data about using some of the oral novel agents in pregnancy, but the long-term data for safety and efficacy in pregnancy is still lacking. And so I think most clinicians still go with enoxaparin, but don't be surprised if, as the data evolves over the next few years, whether or not one of the novel oral agents may have a role here. Gestational diabetes, I'll refer you to the ADA guides for gestational diabetes. We talked about diabetes earlier in the year, but I encourage you to sort of look at that. And most often what you'll see is using insulin, regular or Lispro insulin or aspart insulin. There is data for the sulfonylureas, and while not first-line, metformin has been used in pregnancy pretty widely as well. For pregnancy-induced hypertension, it depends on when it occurs and how high the pressure gets, but always keep in mind in pregnancy, when you see hypertension, whether or not what you could see is preeclampsia or eclampsia. And in those situations, you're looking at aggressive management. Among other things, we'll use mag sulfate there. But we look at always keeping an eye on blood pressure during pregnancy as well. Our treatments and our prevention really is to look at monitoring folks with high risk for hypertension during pregnancy. And at least the older first-line agent still is methyl-dopa. We don't use methyl-dopa for almost any other purpose. But also we'll see beta blockers used, labetalol, and the calcium channel blockers. What we are going to avoid, obviously, are the ACE inhibitors and the ARBs, which we've talked about earlier. And then sometimes you'll need, if you need a parenteral agent, sometimes labetalol or hydralazine are used. But you weigh that, like not overshooting, not overly aggressive with lowering blood pressure too much, because you want to make sure that perfusion is maintained to the fetus and to the other organs in the mother. Preterm labor is a common situation for many women when contractions begin before full term. And so anything before week 37 is considered preterm, and we try to do whatever we can within reason to make sure a woman is fully at term. The older the older the gestational age is, the better outcomes are for the newborn. And so we'll look at both non-pharmacologic and pharmacologic treatment. Non-pharmacologic treatment often involves hydration, bed rest, and sometimes even sedation, although you have to be careful with sedation and the risks for the sedative agents on the fetus as well. And then other treatments we look at are preterm labor. Depends on what we'll see. Sometimes you'll see hydroxyprogesterone acetate given IM, and then we also will sometimes see used short-term, at least it buys you a few days, as sometimes one of the calcium channel blockers. So the tocolytics, the agents that we're going to see, terbutaline or mag sulfate, can be used in addition to the calcium channel blockers, as we alluded to. Terbutaline is probably used pretty frequently in some practice settings, and others we see other things used first. And mag sulfate, if there's any concern for preeclampsia or eclampsia, mag sulfate is given in remarkably high doses in obstetrics, and that's pretty common to see that. You can see used sometimes the prostaglandin synthetase inhibitors. Indomethacin is sometimes used, and the calcium channel blockers we'll see used most often is nifedipine, and nifedipine used careful when you if you're giving it with magnesium, because both the mag sulfate will cause hypotension, as will the nifedipine, so you need to be careful about that. If a woman needs induction for labor, and the indications for that would be whether there's a severe infection, uterine bleeding, preeclampsia, or some other conditions that are listed here, particularly in a woman who's having either prolonged labor or they're beyond 42 weeks. Those were women who might be candidates for induction. And we're going to look at oxytocin here for the most part. So oxytocin is the standard agent you'll see used for labor induction. It's almost routinely given. It will cause uterine contractions, and we titrate it carefully in a drip. An older agent, which is not really used for inducing labor much anymore, are one of the ergot alkaloids. So we don't really see that used. And the prostaglandins sometimes are used, sometimes before oxytocin, as part of a cervical ripening procedure. We see this either with misoprostol or one of the prostaglandin E2 agents. So you'll see those sometimes used for cervical ripening as well. There are some drugs to look at. Basically, just be familiar with some of the contraceptives and estrogen